All right, good morning, everybody. Thanks for joining us for this week's AMSSM Sports Ultrasound case series. My name is Ryan Cruz. I'll be hosting this week. So today we are joined by Dr. Michael Seifert. He's an assistant professor in the Department of Orthopedics, Division of Non-Operative Sports and Musculoskeletal Medicine. He trained at USF Morsani College of Medicine, VCU Health, and Maine Medical Center. His primary interests are in ultrasound-guided procedures and improving orthopedic education for medical students, residents, and fellows across numerous specialties. This morning, he has been generous enough to join us to give us a talk on the sonographic evaluation of the sternoclavicular joint. So with that, I will turn this over to Mike.
Thank you. Thanks for the introduction. Let me just minimize that screen there. Okay. So thanks for the introduction. I'm going to be talking about the sternoclavicular joint today and the ultrasound evaluation of it. As Ryan said, I'm in Department of Orthopedics, so I see only orthopedic and sports medicine issues, and every day, all day. And this is a pretty uncommon joint to have an issue at. So I might see 4 or 5 per people per year. And in terms of what's been described in the literature, there's not much, but there's a great study that I'll show you at the end from a group in France from a couple of years ago, and insights into imaging, and they did a nice, cadaver and ultrasound correlation study talking about the various different anatomical structures, and I got a lot of good data from them. So didn't miss much, just this first slide. So there we go. Okay. So the case introduction to kind of get us in a frame of mind here is this is a 34-year-old left-hand dominant female nurse that I saw a few months ago. She presented with left sternoclavicular pain, so her dominant arm. She participates in high-intensity training exercise, something like CrossFit, 3 to 4 times a week. She'd had pain in this area for about 3 to 4 weeks, or sorry, for 3 to 4 months, and she thinks it started after a lifting exercise. The pain has continued despite, somewhat modifying her activity, but she's still been able to exercise through it. She got referred to from her primary care doctor to a physical therapist and attended about 5 sessions about a month before seeing me, and it didn't really help. She had noted asymmetric swelling of her left sternoclavicular joint compared to her right. No redness or warmth that she ever saw. She didn't have any other shoulder or upper arm symptoms, so nothing in the the lateral shoulder, the neck, down into the hand, no numbness or tingling, and she was otherwise healthy with no medical problems and took no medications. And when I saw her, she was otherwise well appearing. There was very notable swelling of the left sternoclavicular joint. However, she had full range of motion, equal strength, no neurologic symptoms or exam findings, and when I tried to, put her through a range of motion of her shoulder, the sternoclavicular joint did not seem unstable to, to just active range of motion or my direct manipulation. So in terms of a protocol for evaluating the sternoclavicular joint, there are some structures that are visible. It's a very superficial structure, so generally most of the stuff you can see relatively easily. The anterior sternoclavicular ligament is what crosses over the top of the joint, the superficial aspect. Deep to that, there is a posterior sternoclavicular joint, which is not visible. There's an interclavicular ligament that goes on top of the sternoclavicular ligament, superficial to it. Inside the joint, there is an articular disc that is visible in many patients, but not everybody. Obviously, with an ultrasound of a joint, you can look at the bony morphology around the joint, on either side, the capsule size, whether it's distended or not, and then actually do a dynamic exam of the joint under ultrasound. And then based on the clinical need, you might look at other nearby structures such as the shoulder, the ribs, other areas. Obviously starting with a shoulder x-ray. The sternoclavicular joint is obviously towards the left of my screen, and there's no obvious abnormality there. The other views of her shoulder were also normal. So getting to the ultrasound exam after doing a history and physical, this is a long axis view, and I've labeled the manubrium, which is part of the sternum, and then that should be a C, that's a clavicle. It's my fault. the clavicle is on the right side. The thing I noticed right away was that the swelling that's visible externally is visible with the ultrasound. So there is you can see my mouse here, there's, an effusion in this joint. The joint space does not appear widened. It may be actually a little bit narrowed. The study that I referenced from France, they felt that the average ligament width was 0.5 millimeters. So that this looked a little bit narrower than that. There are changes to the bony morphology, and I think there's a little bit of an early osteophyte here and over there. The anterior sternoclavicular ligament is visible here. It's a hyperechoic structure that goes over the top, comes over and goes down. Hopefully, again, you can see that mouse as I did that. That is, in the study and in my experience, not really, you're not really able to assess that differently than the capsule of the joint. The interclavicular ligament is the one that goes above that, so it also starts at the same area, but it continues up, and it's the hyperechoic structure that goes all the way across. And then again, superficial to that is the sternal tendon of the sternocleidomastoid. They're all just kind of mixed together and create the anterior part of this joint. So I took another view. I went from a sort of proximal to distal. Again, the fusion is visible. The sternoclavicular ligaments visible here a little bit, kind of lose it more laterally. And then I went even more distal and then tried to have the patient do a flexion maneuver and an extension maneuver to try to bring their disc into view. The disc, theoretically, and I'll show you a better picture, should be in this space. It would be a hyperechoic structure in between the two bones. On this patient, I was not able to visualize her intra-articular disc, but again, I'll show you a picture in just a second. But there's an effusion that tracks medially, again, a little bit distally. So there's something, there's swelling in this joint. The ligaments appeared relatively normal, perhaps a little bit thickened in this first view. The mean width is 1.5 millimeters, according to that French study. And then I compared it to the other joint, and so this is her right sternoclavicular joint, and the sternum and manubrium was over here. The clavicle is on the left side of the screen now, and I think you can see the obvious difference in that the joint doesn't have an effusion. There's no tenting of that sternoclavicular ligament. Again, just comparing those two, pretty obvious difference. I did a Doppler examination of the joint, and this is back to the left side, same orientation, and relatively quiet from a Doppler perspective. There's no increase in bony perfusion or periarticular perfusion, and then compared it to the other side, which, if anything, has more Doppler uptake, but not a significant difference. And the interclavicular ligament is visible. Again, I tried to put it right here, straight on the sternum, looking at the ligament as it crosses over all the way over, and you can't really view it in one plane with an ultrasound, but it doesn't look thickened or disrupted at anywhere in any of these. And again, these are just example views. I took more pictures, but that is the evaluation that I had performed. I did this dynamic evaluation. Again, hopefully the video will work. This is always the nerve-wracking part of an ultrasound exam. Okay. So there is a movement of the joint here. She's going from extension to flexion and then abduction to adduction, and basically looking to see if there's any sudden popping of the clavicle relative to the sternum. Does it become displaced relative to the sternum? And I would say that on my dynamic evaluation that it ever did. Here is that French study from Olivier. I hope I'm pronouncing that right. And then again, these are some examples of discs that they found. So hyperechoic structures in between the two, and there is some variability. You can see sometimes it's thin, sometimes it's thicker, sometimes it attaches to the joint capsule itself and separates the joint into two sides. So there is some variability, but on my patient, and I was not able to visualize it. And then in the study that was done in France, that they could not find the disc in about 20% of patients. So it's not that uncommon that you won't see the disc. I felt that it was kind of important to go through some pertinent pathology. Obviously, I didn't have a whole lot on mind besides the swelling of the joint and perhaps some mild thickening of the anterior sternoclavicular ligament. But here are some examples of some pathology that you might find in this area, and these are from various websites that I've referenced. And so this is a posterior clavicle dislocation. This is probably the biggest one that you would be most nervous about seeing, is that the clavicle is now pushing downward, especially compared to the contralateral side. You can see there's a very obvious difference, and there are important vascular structures behind there. So this type of ultrasound finding would warrant further imaging and probably in an emergency room evaluation. A sternal fracture is possible. The manubrium and the body of the sternum are here. This is a sagittal view of the manubrium, and there is a small cortical defect right there in the sternal body. So again, depending on the clinical scenario that you're faced with, you may want to extend your ultrasound evaluation to include the sternum. There is another view of the same thing, sort of a little bit more zoomed in, but you can see that very clear step off of the sternal body. A clavicle fracture is, of course, a possibility. When anybody has any sort of trauma around the sternoclavicular joint, you might want to consider a clavicle fracture. Obviously, ultrasound is probably not going to be your first choice for diagnosing that, but this is an example of what a clavicle fracture might look like. I did the Doppler flow on my exam. This was a nurse. She, again, that's just by itself has maybe a risk factor for some sort of unusual infectious process, maybe. But septic arthritis is a possibility in any joint, including the sternoclavicular joint. And here's an example of what that might look like, with a lot of swelling, not just in the joint, but around the joint, and then increase in Doppler flow. So that would be a concerning finding, not necessarily specific to septic arthritis, but in the right clinical setting, it would be. For example of other pathology that we might see would be chondrocalcinosis of CPBD crystals. This was a nice study from Journal of Rheumatology where they did a CT correlation with an ultrasound, and these hyperechoic, or I guess in this case, bright white structures would correlate with the hyperechoic findings on the ultrasound. Only the superficial portion of the sternoclavicular joint would be visible, so these ones that are down here would not be something you can see with an ultrasound. And then, another study that I found relating specifically to the sternoclavicular joint about, this one's about rheumatoid arthritis and some of the findings that you might find. So, synovitis, erosions. I'll show you an example of what that might, and then osteophytes. Osteophytes are obviously not going to be specific to RA. Here is an example of what erosions would look like. So these little sort of divots into the joint. This is on the manubrium side. There might be one over here on the clavicle side as well. That would be suggestive of RA in the right clinical setting. And then sternoclavicular arthritis. This is narrowing of the joint with osteophytes, and I think I saw a very early version of that in my patient. And then finally, this is another patient that I happened to see a few weeks ago after I had signed up for this talk, and she had a sternoclavicular joint cyst. So it's visible right here. I'm aspirating it on this picture, but the cyst was here and was confluent with the sternoclavicular joint. Not the best picture, admittedly, but the cyst went in there, and I talked to her, and she wanted to have it aspirated. So that's what we did. And then, of course, with the sternoclavicular joint, it's part of the shoulder region. You could consider evaluation of the ribs, the shoulder itself, perhaps other structures. Again, as I said, you can extend it to the clavicle or the sternum. But in my specific patient, she didn't really have any history or exam findings that made me worry about other structures in the area. So I kept my mind essentially to the sternoclavicular joint. So here is a sample report. The ultrasound examination of the left sternoclavicular joint. The indication was 3 months of persistent pain and swelling. I used a linear array 12.5 megahertz transducer. The findings that there's mild thickening without disruption of the anterior sternoclavicular ligament with a joint effusion. The interclavicular ligament appeared normal in thickness. There was no increase in Doppler flow in the periarticular area. There were perhaps minimal cortical changes, early osteophytes. The intra-articular disc was not visualized in this individual. And then dynamic evaluation of the joint did not reveal any obvious mobility differences or instability compared to the contralateral side. So my final report was ligament thickening and a small joint effusion consistent with sternoclavicular joint sprain, with perhaps early arthritic change also noted. And again, referencing that study, osteophytes were visible in actually a fair number of relatively young patients. The study from Olivier, they found that the average age of an osteophyte detection with ultrasound on the clavicular side was 42 years, and on the sternal side was 36 years. So this patient being 34 years old, it's actually not that uncommon to have some arthritic change already. And with that, I can take some questions. I can reference some of the other things that I have if there's any.
All right, thanks, Mike. Appreciate you doing that. I guess if anybody has any questions, feel free to throw it in the chat. I'll try to monitor that. Oh, we got one. So Mike, how to treat or based on this ultrasound find?
Yeah, what I decided to do with my patient was, we talked about what she could do. She could continue with physical therapy. She could limit her activity. She hadn't really rested. Excuse me. She hadn't really rested very much, so she could take, some period of time off. That's not really well described in any literature findings that I found, like in terms of what's enough. We talked about topical NSAIDs, which she hadn't tried, but we also talked about a joint injection. And that's what she ultimately decided to do. She wanted to have, fast relief. So I did a 10 milligram Kenalog injection under ultrasound guidance into her joint. And that was 3 to 4 months ago. And she sent me a message a couple weeks after the injection and said that it was feeling better. And I haven't heard from her since then, so I assume it's still doing well. But that's what I ultimately did in this patient. That is, of course, not the only treatment option, but that's what my patient chose.
Great. All right. Any other questions? Feel free to throw them in there. I'll just make a couple comments here quickly. So I think you kind of alluded to this. When I'm evaluating this region, my goal always is to try to fulfill the requirements for a complete examination. So as you mentioned, the shoulder is a region that I'll evaluate pretty much every time there's concern for an SC joint pathology, just because there can be other concomitant structures that may have pathology. Certainly some primary shoulder problems can potentially refer medially at times towards the SC joint. So just for me, in order to perform a complete examination, I will add in the structures of the shoulder as well, even in somebody who's got focal SC joint pain. One thing to mention, so transducer orientation for the SC joint is very much different than transducer orientation for the AC joint. So if you think about the orientation of the SC joint and your transducer, I think the tendency when you're looking at the SC joint and essentially a transverse view, you're not in a true axial position. So when you're trying to get that perfect image of your joint, the medial aspect of your transducer is going to be a bit caudal. So it's going to be essentially an axial oblique plane to really line up in a true transverse view of the SC joint. And that's one thing I see, as residents and fellows are starting to learn how to, identify AC joint and SC joint. It's those subtle transducer motions can really help to better optimize the orientation and the image of the sternoclavicular joint. The images that you showed in the layer of structures overlying the SC joint were great. So that deepmost layer spanning between the sternum and the clavicle, as you mentioned, is the anterior sternoclavicular ligament. Also, as you mentioned, there is a posterior SC ligament, which you can't really see or evaluate on ultrasound because of its deep and posterior position. And then immediately overlying that, like you mentioned, is going to be your interclavicular ligament. And that's a fairly broad ligament. And because of the width of most transducers, like you said, Mike, you're not going to be able to evaluate the whole thing unless you either, one, take segmental pictures and look at it in separate pieces, or if your ultrasound unit has a EFOV or extended field of view option on there, that'd be the other way to get the entire ligament in view. And then also, as you mentioned, just superficial to that, you're going to have your sternal attachment of your SCM. So just making sure you know what those layers are to be able to best evaluate them individually. The other thing to mention, the other structure, well, two other structures in this region that just should be noted. So if you slide the transducer just a bit caudal or inferior from where you're at on the SC joint, that's where the articulation of your first rib is going to be. So if concerned about pathology there, again, sliding just caudal, you can evaluate that region there. And then obviously along the entire lateral extent, or for most of the lateral extent of the sternum, you're going to have your sternal head pec major tendon attachment. So just another structure in that region just to be mindful of, because while not common, you can see pathology at that sternal attachment of the pec major muscle.
Yes, great point.
I think those are my biggest points. But yeah, I mean, it's certainly not a region or not a structure that's evaluated all that often. It's certainly not nearly as commonly injured as other structures in the shoulder, like the AC joint and rotator cuff and whatnot. But it is something that does happen, and being able to evaluate all the structures that you mentioned, not just the joint, but the overlying ligaments and whatnot, are important. Any other questions in the chat here? I don't see any. All right. Hearing none or seeing none, we will wrap this. So, Mike, thanks again. We all appreciate you doing this. These videos are incredible educational resources, and this will add to that library. So thank you, and we appreciate you doing this for us. As always, we are off next week, and we'll be back in 2 weeks from now for our next presentation. So thanks everybody for getting up early, and have a great weekend.
Thanks, Ryan.